Every single movement your body makes, from blinking your eyes to sprinting across a field, is the result of an incredibly precise mechanical system. The human body is not just a collection of bones and muscles. It is a biomechanical masterpiece built on planes, axes, and specialized joint mechanics that have been refined over millions of years of evolution. In medicine and anatomy, understanding exactly how the body moves is just as important as knowing where structures are located. Before a surgeon can repair a joint, before a physiotherapist can rehabilitate an injury, before a doctor can diagnose movement disorders, they must first understand the architecture of human motion. In this video, Studious is going to take you through that entire system from the ground up. By the end, you will have a complete biomechanical blueprint of the human body locked in your memory.
Before we can describe any movement, we need two things: a starting point and an understanding of how movements are organized. The starting point is the anatomical position: body upright, head facing strictly forward, arms relaxed at the sides, and palms facing anteriorly. Every movement in anatomy is described relative to this locked baseline, regardless of what position the patient is actually in. Now, here is the law of opposites, also called the principle of antagonism, and this is absolutely critical. Muscles can only pull, they cannot push. This means that every movement in one direction must have a paired opposing movement to return the joint back to baseline. Think of it like a system of interlocked gears. No movement exists in isolation. Every flexion needs an extension. Every abduction needs an adduction. This pairing principle governs the entire mechanics of the human body.
To understand movement, you must first understand how a single biological joint actually works. Let's use the knee as our model. There are four key components at play. First, the fixed point, in this case, the thigh. This is the stationary anchor. All movement is defined as the change in position relative to this fixed structure. Second, the object, the lower leg. This is the dynamic structure that actually moves through three-dimensional space. Third, the fulcrum, the knee joint itself. This is the specific pivot point within the articulation around which motion occurs. Fourth, the axis, a mathematical straight line running through the joint around which the rotational movement takes place. In the knee, this is the sagittal plane axis. Every single joint in the human body operates on this same four-component model. Understanding these mechanics is the foundation for understanding every movement term that follows.
Now we need to map where movement happens. The human body operates in three-dimensional space, and anatomists divide that space into three intersecting planes. The first is the sagittal plane, a vertical plane running front to back, dividing the body into left and right halves. Forward and backward movements, like nodding your head, happen here. The second is the coronal plane, a vertical plane running side to side, dividing the body into front and back halves. Side-to-side movements like raising your arms out laterally occur in this plane. The third is the transverse plane, a horizontal plane that divides the body into upper and lower halves. Rotational twisting movements happen here. Think of these three planes as a 3D coordinate grid overlaid on the body. Every movement you will ever describe in anatomy belongs to one of these planes, and knowing which instantly tells you the direction and nature of that movement.
The most common movements you will encounter in anatomy are flexion and extension, and both occur in the sagittal plane. Flexion is the movement that decreases the angle between two body segments at a joint. When you bend your knee to lift your foot off the floor, that closing of the joint angle from 180 degrees toward 90 degrees is flexion. Extension is the opposite. It increases the joint angle, straightening the limb back out toward or beyond baseline. Now, here is a crucial distinction for your exams. Simple joints, hinge joints like the knee, elbow, and finger joints, can only perform flexion and extension. They are mechanically restricted to this one plane of motion. Compound joints, like the shoulder, hip, and intervertebral joints, have far greater range and can perform movements across multiple planes. Knowing which joints are simple versus compound will save you from many clinical errors down the road.
Moving to the coronal plane, we encountered two more essential paired movements, abduction and adduction. Abduction is movement away from the midline of the body in the coronal plane. When you raise your arms straight out to the side, that is abduction. Adduction is movement toward the midline. When you bring that arm back down and across your body, reaching approximately 45 degrees past the baseline, that is adduction. A great mnemonic. Abduction equals away. Adduction adds back to center. Now, there is a special case for midline structures, like the spine. When the spine bends sideways, say tilting your head toward your right shoulder, that is called lateral flexion, and you must always specify the direction. You would say right lateral flexion, because the spine sits on the midline and cannot abduct or adduct in the traditional sense. This distinction matters enormously in clinical spinal assessments.
Rotation is the defining movement of the transverse plane, and it comes in two distinct types. For limbs, arms, and legs, rotation is described as internal or external. Internal rotation, also called medial rotation, is when the anterior surface of the joint twists toward the midline. Think of turning your toes inward. External rotation, or lateral rotation, is when the anterior surface twists away from the midline, turning your toes outward. But rotation works differently for the trunk and head. Because the spine itself sits on the midline, the terms internal and external don't apply. Instead, rotation of the trunk and head is defined purely by direction, left rotation or right rotation. This axial rotation occurs primarily in the cervical and thoracic spine and is what allows you to look over your shoulder. The lumbar spine, by contrast, has very limited rotation due to the orientation of its facet joints, which prioritize stability over mobility.
Here is where human anatomy becomes truly fascinating. Standard rotational joints are excellent for stability, but the demands of survival, eating, crafting tools, navigating terrain, required something more. So evolution developed 3 specialized joint systems that bypass the restrictions of standard movement. First, the temporomandibular joint, or TMJ, which gave the jaw the ability to open far wider than a purely rotational joint would allow, critical for dietary adaptation. Second, the hand and forearm, a system of compound and saddle joints that generates the precision grip and fine motor control required for tool crafting and writing. Third, the ankle complex, a multi-planar joint system that allows the foot to adapt in real time to uneven terrain, enabling predator evasion and sustained locomotion. Each of these 3 systems represents a targeted evolutionary solution to a specific survival challenge, and we will explore each one in the slides that follow.
The jaw is unlike any other joint in the body, and here is why. Most joints are purely rotational. They spin around a fixed axis. A purely rotational jaw could only open approximately 20 millimeters, which is barely enough to take a small bite. The TMJ solves this with a process called translation, movement without rotation. When you open your mouth widely, the jaw first depresses, moves inferiorly, then undergoes protrusion. The condyle slides forward out of its deep socket in a process of intentional, temporary destabilization. By escaping the boundaries of its socket, the jaw gains a massive increase in range of motion, allowing you to bite into large food items. Retrusion then safely pulls the condyle back into its socket. Depression and elevation handle the vertical open and close motion. This combination of rotational and translational mechanics makes the TMJ one of the most biomechanically unique joints in the entire human body.
The shoulder and forearm together represent the most mechanically sophisticated region of the upper limb. The shoulder joint is capable of circumduction, a complex compound movement that traces a cone shape in space. It is achieved through infinite minute changes in flexion, extension, abduction, and adduction occurring in rapid sequence. Circumduction is present in the shoulder, hip, fingers, and thumb, and is essential for tasks like stirring a pot or throwing a ball. The forearm adds another layer of mechanical sophistication through supination and pronation. Supination rotates the forearm so the palm faces upward. Think of holding a bowl of soup. Pronation rotates it so the palm faces downward. These movements are generated by the radius crossing over the ulna at the radio-ulnar joints and are what give you the unique dexterity required to use a screwdriver, turn a key, or twirl a fork, everyday actions that no other primate can perform with the same precision.
The hand is arguably evolution's greatest mechanical achievement. At the wrist, the hand can perform coronal wrist deviation, bending toward either side. Ulnar deviation angles the hand toward the ulna, which is the pinky or medial side, with a normal range of about 40 to 60 degrees. Radial deviation angles the hand toward the radius, the thumb or lateral side, with a smaller range of roughly 20 degrees. But the true marvel of the human hand is the opposable thumb, made possible by the body's only saddle joint at the carpometacarpal joint of the thumb. This unique joint allows the thumb to sweep across the palm in a motion called opposition, bringing the thumb pad into contact with the fingertips. Combined with finger flexion, opposition generates both powerful gripping force and microscopic precision. Reposition returns the thumb to its resting position. Without this single joint, human civilization, writing, surgery, art would be impossible.
The ankle and foot have a completely different mechanical priority from the hand. Where the hand is built for precision, the foot is built for power, stability, and terrain adaptation. There are 4 key movements here. Plantar flexion points the foot downward through the sole. This is the explosive push-off motion used when sprinting or jumping. Dorsiflexion pulls the foot upward toward the dorsum, the top of the foot, essential for walking and absorbing landing impact. Inversion turns the plantar surface of the foot to face medially, inward, allowing the foot to grip uneven surfaces. Eversion turns the plantar surface to face laterally, outward, allowing dynamic weight shifting. Together, these 4 movements allow the foot to maintain stability and shift direction at full speed across completely unpredictable terrain, a critical adaptation for both athletic performance and basic survival locomotion.
Now we bring everything together into one comprehensive reference framework, the Master Movement Matrix. Flexion and extension occur in the sagittal plane around a transverse axis, primarily at the knees, elbows, and fingers. Abduction and adduction occur in the coronal plane around a sagittal axis, primarily at the shoulders and hips. Internal and external rotation occur in the transverse plane around the long axis, again at shoulders and hips. Depression and elevation of the mandible occur in a sagittal translational pattern at the TMJ. Supination and pronation are transverse plane movements along the long axis of the forearm at the radio-ulnar joints. And finally, inversion and eversion are coronal plane movements at the ankle complex. Study this matrix until you can recall it from memory. In clinical exams, in OSCEs, in ward rounds, this table is your cheat code for describing any movement of the human body with complete anatomical precision.
Understanding normal movement mechanics is what makes abnormal mechanics immediately visible, and this is where anatomy directly saves lives. The clinical example here is rheumatoid arthritis, an autoimmune condition distinct from osteoarthritis or septic arthritis. In a healthy hand and wrist, ulnar deviation is a controlled, voluntary coronal plane movement with a normal range of 40 to 60 degrees. In rheumatoid arthritis, repetitive microtrauma combined with severe autoimmune inflammation structurally compromises the joint capsule and surrounding ligaments. The result is chronic, involuntary ulnar deviation. The fingers permanently drift toward the medial ulnar side, even at rest. This is not just a cosmetic deformity. It represents complete mechanical failure of the coronal plane control system of the hand. Recognizing this as an abnormal coronal movement, rather than just crooked fingers, allows a clinician to immediately understand the structural damage and guide treatment accordingly.
The final piece of the biomechanical blueprint is clinical diagnosis, specifically the technique of joint isolation. When a patient presents with restricted or painful movement, the challenge is proving that the abnormality originates from one specific joint and not from a compensating neighboring structure. The isolation protocol has 3 steps. Step 1, anchor the baseline. Firmly grip the proximal side of the target joint, stabilizing the bone closer to the body's center. Step 2, eliminate compensation. By holding the proximal structure completely fixed, you physically prevent neighboring joints from mimicking or absorbing the movement and masking the true deficit. Step 3, test the mechanics. Manually guide the distal structure through its expected planes of motion to confirm true localized range of motion, or to isolate the exact source of inflammation. This technique transforms abstract anatomical knowledge into a precise, repeatable clinical tool. It is the bridge between understanding anatomy on paper and applying it at the bedside.